We're on the videotape record. Time is approximately 18 minutes after 2 o'clock. Today is the 26th day of February, 2018. My name is Tom Eller. I'm from Trey Video with offices in Milltown and Pittstown, New Jersey. Will the court reporter please swear in a witness?
Doctor, please raise your right hand, sir. Do you solemnly swear that the testimony given in this matter will be the truth, the whole truth, nothing but the truth, so help you God?
I do.
Will the attorneys please identify themselves for the record?
Thomas DeSeno, Chabelle, and Many on behalf of the plaintiff Monica Bernal.
Laura Gifford from Steliadis and Jackson on behalf of defendant Nicholas McNeil.
May I proceed?
Thank you. Doctor, this is Tom DeSeno talking. I represent the plaintiff, and we're here today to put your testimony on the record for the jury. Before we get to your treatment of the plaintiff Monica Bernal, I wanted you, if you would, to please take the jury through, we'll go first through your educational background.
Sure. So I graduated Rutgers College in 1975. I then went on to New York Medical College from 75 to 1979. When I graduated New York Medical, I did a surgical internship at the Albert Einstein College of Medicine, Montefiore Medical Center from 79 to 1980, and then stayed on at Montefiore Einstein and did an orthopedic surgery residency from 1980 to 1984. And when I completed my orthopedic surgery residency, I opted to do a spine surgery fellowship at the Hospital for Special Surgery, Cornell Medical Center, New York Hospital, from 84 to 1985, and then joined Shaw Orthopedic Group.
Okay. And doctor, are you board certified?
I am board certified. I'm board certified in orthopedic surgery in 1987. I am board recertified in orthopedic surgery 3 times, the last being 2016. In 1998, the American Board of Spine Surgery was created because spine surgery is a very unique and specific specialty. So I was one of the first 100 doctors in the United States to be offered that exam and became a charter fellow of the American Board of Spine Surgery in 1998. And then I'm recertified in spine surgery twice, the last being 2015.
And doctor, can you tell me in that educational experience, obviously, you began doing orthopedic surgeries at some point during that field of study?
Sure. I mean, you start doing that during your internship, frankly.
Okay. So how many years did you say you've been doing orthopedic surgeries?
Well, again, I started my internship in 1979. So since 1979,
Okay.
certainly in my orthopedic residency in 1980, since then.
All right. And also involved in that field of study, was there MRI work looking at and interpreting them?
Sure. So again, as an orthopedic surgery resident and fellow, MRIs are imaging modalities that you use to evaluate a patient. You learn how to examine a patient, you learn how to take a history from a patient, and you learn how to evaluate their imaging. In 1992, I presented a paper, I wrote a paper and presented it on MRI as a sole imaging modality for anterior cervical surgery. It was presented at the Cervical Spine Research Society, which is an invitation-only society. And at the time, it was an important paper because they were using myelograms, which is an invasive study, rarely used today, although occasionally. And this was a paper that showed that the MRI was as sensitive and as good for indicating surgery. So not only do I know how to read an MRI and work with MRIs every day and personally review them, I actually wrote about them.
Okay. So you said you joined Shaw Orthopedic Group here in 1987. So you've been
85.
85, okay. So you've been here over 30 years and practicing as an orthopedic surgeon that entire time?
Yes.
And do you are you affiliated with any hospitals in the area?
Yes, I'm an attending orthopedic surgeon at Monmouth Medical Center, where I'm also past president of the medical staff at Monmouth. I'm an attending orthopedic surgeon at Riverview, and I'm previously spine consultant to Central State.
Okay. And doctor, because the jurors may not know, could you take me through what an orthopedic surgeon does almost on a daily basis as far as seeing people, doing surgeries and the like? What's a week in the life of an orthopedic surgeon?
Well, it depends on what the orthopedic surgeon does, but my practice is limited to spinal surgery. I'm an active treating doctor. I see patients, I evaluate them. I'll operate on them when it's appropriate. I operated Friday. I'm operating tomorrow. I'm operating this Friday. And I, see patients several times a week, and I operate several days a week. And again, if you're actively treating people, this is what you do.
Okay.
You take a history from the patient, you examine the patient, you review their imaging studies, and you come up with a treatment program for them.
Okay. Doc, at this time, I'd like to offer Dr. Glasstein as an expert in orthopedic surgery.
I'm just going to reserve any questions on the qualifications for cross, but no objection at this time.
Okay, thank you. Doctor, I'd like to take you at this time to your treatment of Monica Bernal. Was Monica actually a patient of yours?
Yes.
Okay, and you wrote a report in this case. I have it. It's dated April 14 of 2016. If you need to refer back to that report to refresh your recollection, you can feel free to do so.
Sure.
Could you tell me first, when Monica came to you, did you take a history from her?
Yeah, so sure, I will refer to the report. Ms. Bernal presented to me on April 8, 2015, as a 47-year-old female involved in a motor vehicle accident on July 2, 2014. She was a restrained driver of a Toyota R4 that was struck from the rear. She presented to Central State Medical Center's emergency room. X-rays were taken. She was seen, treated, and released. She was complaining of neck pain and lower back pain. She had a history of being seen by Dr. Stephen Chalnick, a chiropractor in Freehold. And she was complaining of neck pain going to the shoulders and to the arms, along with lower back pain going to her left buttock.
Okay. And after taking a history from her, did you do any kind of physical examination of her?
Yes, again, referring to the note of April 14. Initial physical exam revealed a well-developed female. She was walking normally. She had no limps, no abnormal gait. As far as her neck is concerned, she had tenderness present. Sperling's test was positive on the left, so as you rotated and had some compression and extension, she had pain down her left arm. Her motor strength was normal. She had sensory dysesthesias into the left thumb and index finger, meaning that when you examined her on her left side, she had decreased sensation into the left thumb and index finger. That generally goes along with what's called a dermatome. Different nerves go to different parts of the body, and you can map it out, and that was going along with the C6 nerve root. Her reflexes, her biceps reflex was 1+ on the left, 2+ on the right. Her triceps and brachioradialis reflexes were 1+ on the left and 2+ on the right. And no atrophy of the muscles was noted.
Okay. Doctor, you took us through quite a bit there, and I want to just go over some of it and break it down for the jury a little bit. As I understand it, what you look for in a physical exam is positive signs, meaning something's not normal, and then negative signs, meaning something's within the realm of normal, correct?
Yeah.
Okay. As for the things that were not normal, I noticed you put down tenderness. Is that a finding that's a positive finding, not normal?
Yes, it is a positive finding. That's not normal. Again, if you touch my neck, you touch your neck, you're not going to likely have tenderness, whereas she reported she did.
Now, the Sperling test, you said, could you just give the jury, because obviously they may have never heard it before, a little bit of an introduction to that, what it is and what it showed?
When you rotate and extend your neck and then have a little compression, you can put pressure on the nerve root as it exits, and that's called a positive spurling. And again, it usually goes along with some type of compression or narrowness in the area where the nerve exits.
Okay, and we're going to get into the nerves in the spine and the leg. So basically, am I correct in saying what that test showed you was that there's something going on with the nerves in her neck?
Yeah.
Okay. You had also mentioned a positive finding of sensory dysesthesia.
Yeah.
And could you tell the jury what that is and how that was important to your findings?
Well, it's especially here where it went into her thumb and index finger, which is really C6. It goes along with the fact that sensation on the left, where we now know she had compression, is affecting the C6 nerve root. So dysesthesias are abnormal sensory findings.
Okay, so there's an abnormal sensory finding going all the way down to her fingers, but the problem that's causing that is located somewhere in the neck?
Yeah.
Okay, and we'll get back to that when we show the model of the spine. On the reflexes, you said that the bicep reflex was 1+. Now, I understand there's some kind of scale with 1+, 2+, and on and on. Could you educate the jurors on what that scale is and what a 1+ would mean?
Sure. So generally, 2+, 3+ is normal, 1+ is less, greater than 3+ is what's called hyperreflexia, and both can be abnormal. 1+, if it's decreased, shows that the reflex isn't working so well. Okay. Greater than 3+ implies what's called an upper motor neuron finding that it's not that it's working better, but it's hyperreflexic. In this case, the nerve, the 6th nerve reflex is less. That's somewhat of her biceps and somewhat of her brachioradialis, which is on the left.
Okay.
Her right side, and again, I will eventually show you the MRI, you can see that she has a disc herniation mostly to the left.
So your physical examination was showing problems more so on the left than the right?
Yeah.
Okay. Now, doctor, if we could maybe show that, I want to talk to the jurors about what a healthy spine looks like and how healthy discs operate. So we can get the jury a baseline to understand what the spine and the discs are. So we have that there. What I'd like you to do is concentrating, if we could, on the cervical spine, where Ms. Brunel's problem is.
Sure.
If you could take the jurors through the parts of the cervical spine and what are their functions.
Sure. So again, it's the whole spine. The brain becomes a spinal cord. In the neck, it's called cervical. In the mid-back, it's called thoracic. And in the lower back, which connects to the pelvis and sacrum, it's called lumbar. So here, we're mostly going to concentrate on the neck, which is cervical. So discs are cartilage shock absorbers, so to speak, or cartilage entities that separate bones. They allow motion. They act as a joint. So you'll have two facet joints. You'll have the cartilage front or disc. And in a flexion extension type of injury, you can have a tear of what's called the annulus. So the disc is composed of two parts, a thickened annulus and a gelatinous nucleus. The annulus tears with trauma. It allows the gelatinous, the jelly-like nucleus to pop out, and it almost always pops out posterior or backwards. That's where the nerves are. It can hit the nerve or encroach upon the nerve, and that's when you start to get very specific findings consistent with a pinched nerve, as they say.
Okay. On that model that you're looking at, so I'm clear, the yellow structures are the bones, correct?
Yeah. So these are bones.
And then the white.
And then the white is the disc.
Those are the discs. And you say those are the annulus is the outside of the disc, and inside there's more material that if the disc has a problem, I guess that can come out.
Yes.
Okay. One of the functions of the discs, or what are the functions of the disc, so that the jury can understand?
The main function is, again, it forms what's called a trijoint complex. Each level, if you didn't have a disc, you would just have bone. If you had bone, there'd be no motion. There'd be just one big solid bone. And there are disease entities like ankylosing spondylitis that the disc becomes calcified. There is no motion. So the main function of the disc is to allow motion and to allow motion around each individual segment. So it's not just one long hard bone. That's the main function. It also protects the spinal cord. It also can act a bit as a cushion. But mostly it's part of this trijoint complex.
And doctor, with respect to the nerves that come out of the spinal cord, are the discs involved in keeping a clear path for those nerves?
Well, again, yes, the disc should be contained. And the nerves, although you don't see it on this model, nerves exit. So if you can see through here, this orange structure is trying to depict the spinal cord. And at each level on both sides, nerve roots exit. That's what the disc is protecting. As they exit these holes here, called the foramen, they go into the arms. In the arm itself, or in the axilla, they will form with other nerve roots, and then they'll form peripheral nerves.
Okay, so the nerve root that's coming out, that can go from the cervical spine, that goes down the arm,
Yes.
and that nerve will service, say, the fingers?
Yeah, it depends on which nerve it is.
Okay.
So the lower down will service the fingers, higher up will service the upper arm. C4-5
Okay.
will service the upper arm, the shoulder.
Now, if something happens to the disc where it's now there's a problem with the space that the nerve has to get out, that can cause problems down in the fingers, like you were talking about earlier with that Sperling's test.
Right, that's the pinched nerve. That's where the nerve itself, it can get pinched any place. It can get pinched centrally. It can get pinched leaving that area of the canal. It can get pinched in the foramen, wherever the disc is herniated, sure.
Okay. Now, we just mentioned herniated. If you could talk to the jurors, what is a herniated disc, and how does that become a problem?
Well, again, when the disc is contained in its space, it's a normal disc, and nothing happens. But if you have trauma and there's a tear in what's called the annulus, and the jelly-like part, the nucleus, starts to herniate or regress out or push out, it can push on a nerve, it can push on the spinal cord, and give one pain in the neck, pain in the arm, pain into fingers. It depends on the location.
And when you said that can happen from trauma, could you be a little more detailed? What kind of trauma can cause a disc to herniate?
Well, any type of trauma can cause a disc to herniate, but very frequently it's a hyperflexion extension injury where that disc is, or the annulus is pushed forward under compression, pulled back under extension, and then again, that's where the annular tear comes in, and that's where the material starts to pop out.
So, doctor, hypothetically, if a person was in a car accident, say, and got struck in the rear, and because of that striking in the rear, their head snaps back, is that the kind of trauma that can cause a herniated disc?
I'm just going to place an objection.
We're back on the videotape record.
So yes, I mean, again, with flex and extension, that nuclear material can herniate out.
Okay. Doctor, did you actually review the MRIs of Monica Bernal?
I did.
And I understand we have those MRI films here, and we'll probably go off the record for 1 second while you queue up the frame that you want so we can talk about that.
Sure.
Going off the videotape record. We're back on the videotape record.
Okay, Doctor, the videographer is now zeroed in on the film that you have up on the screen there. Could you tell us what that film is? Give us the date and the slice so that counsel
Sure.
can keep track of which slice we're talking about.
Sure. So it is Monica Bernal. Her birth date through 768. The date, 10/18/14. And this is a sagittal scan. So this is a lateral or a sagittal scan.
Okay.
And what you can see is her brain, the spinal cord. This is the front. This is the back. These are the bones. That's a bone. This is bone. This is bone. This is bone. And this is disc, 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 disc.
Okay.
And you can see at the levels we're entering lower down in the neck that all her discs are healthy and that they're sharp. They're tight to the back. All this white here, epidural space, is good. And then the rest of the stuff isn't.
Okay.
So we also count. So I know for a fact that this is C2, C3, C4, C5, C6. Discs are named by the bones they separate. So this is the C5-6 disc
So that's separating bone number
5
5 and 6.
and 6.
Okay.
And again, you start counting from 2, and that we know.
Okay.
So again, it's flat, everything looks flat. And in C5-6, there is a nice sized disc herniation approaching the cord at the C5-6 level.
Okay. So that's a finding that's not of a normal spine. That's a problem right there. That's
Right, because here is normal. Here is definitely normal. Here is normal. These are normal discs.
Okay.
But this is clearly not normal. This is a lot of disc material pushed up against the posterior longitudinal ligament, this black line.
That's the ligament that protects the spinal cord.
Yeah, well, yes.
And the hernia, the disc that we see there, is that one where the surrounding part of the disc is ripped open and disc material has dropped out or pushed out?
Yeah, you'll see that again on the other view, but all of this material from here, let's say to here, is pushed out, yes.
Okay. So her problem that you see on this film, is that C5, C6?
That is C5, C6,
Okay.
yes.
Now, you mentioned something about another film. Was there something else you thought would help the jury if they saw?
I do. So this is an axial film, and I'm just scrolling to where I saw before. Here. So here you can see that there's a disc, and that more towards the left, where this is the right,
Okay.
here's the left. There is disc material that's taking up that foramen.
What is a foramen?
The foramen is where the nerve exits.
Is that a hole, a foramen?
It's a door, like
Okay.
say. It's a door, allows a nerve to exit.
Okay. So the nerve coming off the nerve root coming off the spinal cord exits through the foramen.
Right.
Okay.
And you can see it on a few of these shots. So this is a little bit of a more close-up.
Okay.
And here, so here's the right foramen at 5-6, and it's not bad. But look at how all that disc material
Okay.
is taking up this door.
All right.
And as the nerve exit, it's being squashed in here.
Okay.
And all this is herniated into the foramen. Again, there's plenty of central material, but it's really bad in the left foramen.
Okay. And doctor, you said this was an axial view. Can you tell the juror what they're looking at there? How you get an axial view? Where do you cut the person?
Sure. So, okay, so we'll go back to the sagittal view, any level. And so that view is cut cross-sectional. So this is the view up and down, and the axial view is like this, cut right through the disc.
So if we were to cut the person in half and look down inside their body, that's the axial view?
Yes.
Okay. And so both of those views, the sagittal and the axial, do they both show a problem at C5, C6, a herniation?
They do.
Okay. Doctor, if I could talk to you about a herniated disc for a second, is that a permanent condition?
It is permanent because discs live under what's called positive pressure. So the annulus contains it. The nucleus is in there. Once the nucleus pops out, it's positive pressure. There's no negative pressure sucking it back in. It's always pushing stuff out, and that's why with time, it generally pushes out more and more and more. And also with time, the soft disc herniation, especially in the neck, becomes calcified and it becomes hard, and that's when they call it a disc osteophytic complex. So now it's a herniated disc and soft, it's cartilage, but eventually it becomes a rock.
Okay. So, doctor, your opinions in this case have to be offered within a reasonable degree of medical probability. Have any opinions you've offered so far been within that realm?
They all have been, yes.
Okay, and I'm going to ask you now about your diagnosis that you found from Monica Bernal, and I'll ask you again to state your opinions within a reasonable degree of medical probability. What was your findings with respect to Monica Bernal?
Well, again, in her neck, she has a disc herniation mostly to the left at C5, C6. This was very consistent with her complaints of neck pain going into the left arm with a positive Sperling's test, an objective test on physical exam, with her sensory dysesthesias, with her reflex changes, all consistent with that foraminal, what we call stenosis or disc herniation of C5-6.
Okay. And doctor, I want to talk to you for a second about objective versus subjective testing. What is an objective test? What is a subjective test?
An objective test is one that can be reproduced. So an MRI is the ideal, perfect objective test. It's a picture. She goes into the machine, the MRI generates a picture. No matter whatever machine she goes in, she can go on a Monday, a Tuesday, or a Wednesday, you're going to get the same result. That's an objective test versus a subjective test, which the patient has some subjective response over, some way that, she can influence the result.
Okay. And doctor, in this case, with respect to a disc, once it's herniated, and in this case, as you said, it's enclosing upon that foramen, is that disc functioning normally?
No, because again, we went through the function of a disc, which is to be contained, which is to act as a part of a joint, and which is to allow motion, pain-free motion. Okay. Here, part of the disc material is already sitting out, already pressing on a nerve, and whenever there is motion there, that's when she feels pain, tingling, numbness down the arm.
Okay. Will her disc ever heal to function normally?
No.
Okay. Doctor, if I could try to tie in the two ends here, going back to your physical exam and then to the MRI. During your physical exam, you said that you found tenderness in the spine, correct? And the Sperling's test was positive on the left, right?
Yes.
And the sensory dysesthesia, that was also on the left, correct?
Yes.
You mentioned something about the dermatome. Could you just go over that again with the jury?
Again, that's the thumb and index finger. The C6 nerve root, a disc herniation of C5, C6 generally affects the 6th nerve root. That's just anatomy, that's just neurology. And that 6th nerve root goes generally to the thumb and index finger.
So also you said that the reflexes were somewhat compromised on the left as opposed to the right, correct?
Yes.
So, and then when you finally did look at the MRI, the C5, C6 disc problem was also oriented to the left, correct?
It is, yes. I mean, that's very obvious on the axial view.
So the MRI is that something you use to confirm the physical findings from your physical exam?
Sure.
In this case, was it